Hello everyone. Today we are discussing very important topic, developmental abdominal aortic coarctation and hypoplasia. Classification is anatomical classification. We have coarctation arise above the diaphragm, below diaphragm, which is called mid-aortic syndrome. According to the narrowing and the C extension of the narrowing, we have suprarenal, the most common percentage, intrarenal, and then infrarenal. So this is the suprarenal narrowing and hypoplasia of the aorta with the superior mesenteric artery narrowing and the ostium, which is the most common type, suprarenal. We have intrarenal aortic hypoplasia or narrowing with renal ostium stenosis in both sides, and this special for the infrarenal aortic hypoplasia. So the anatomical classification of the developmental abdominal aortic coarctation and hypoplasia, either above the diaphragm or below the diaphragm, which is called mid-aortic syndrome, suprarenal, intrarenal, and infrarenal. Embryology. The first theory is overfusion of two dorsal aortas during the 4th week of the gestation, which is the most common cause of the developmental abdominal aortic narrowing as a theory. Failure of the fusion of the two dorsal aorta or the subsequent obliteration of one is also a theory. The loss of the paired lumbar arteries within hypoplastic aortic segment with only single lumbar artery trunk existing the dorsal aorta, and the aortic developmental occur in association with them multiple renal artery. Why? Being we have narrowing of the aorta, we have a disturbance of the flow and turbulence, which is persistent at the ostium of the renal artery, and it causes resistance of the multiple or accessory renal artery. So when you can discuss this point, it will be as the following. The first, he told us that overfusion of the two dorsal aorta. This is two dorsal aorta, and it's normally getting fused. If we have overfusion, okay, between the two dorsal aorta, it will cause narrowing. If we have obliteration of the one dorsal aorta and resistance of the other, it will cause hypoplasia or narrowing. So this is the two theory for the mid-aortic syndrome or hypoplasia. And about the multiple renal artery, we have developmental and involution of the multiple metanephric artery in association with the aorta. We have narrowing of the aorta. Disturbance occur at the ostium of the renal artery, which allow adjacent metanephric channel to be persisted as a multiple or accessory renal artery. And this is the pictures of the hypoplasia of the aorta with multiple accessory renal artery. Loss of the paired lumbar artery within hypoplastic aorta with only single lumbar artery trunk existing the dorsal aorta. This is the picture of the intrarenal aortic hypoplasia with a single lumbar artery. Okay. Other theory is viral-mediated infection affected the fetal mesenchymal tissue organization and growth. Cytomegalovirus and rubella inhibit cell proliferation and affect the internal proliferation cause internal hypoplasia. Neurofibromatosis type 1 is also associated commonly with aortic coarctation and renal artery stenosis. It has abnormal smooth muscle growth. Inflammation, pan-aortitis with adventitial or peri-adventitial fibrosis. In aortic coarctation, supradiaphragmatic type often present with hourglass narrowing representing lack of growth in developmental lesion or circumferential coarctation in case of inflammatory aortitis. So the etiology and embryology for the mid-aortic syndrome are the following. The first is overfusion of the two dorsal aorta. Second, failure of the fusion with the obliteration of one and resistance of other hypoplastic. We have all the single lumbar artery. We have associated multiple or accessory renal artery. We have viral-mediated infection affected the mesenchymal tissue organization and growth. We have neurofibromatosis association with abnormal smooth muscle growth. We have inflammation, pan-aortitis with the adventitial or peri-adventitial fibrosis. And in case of the supradiaphragmatic aortic coarctation, the etiology is either growth defect, embryology growth defect, or inflammatory aortitis. So the association are the following: neurofibromatosis type 1, Williams syndrome, Argyle syndrome, tuberous sclerosis, inflammation, arthritis, non-developmental abdominal aortic coarctation due to umbilical artery catheterization during neonatal periods, aortic thrombosis, myocardial aneurysm, renal and visceral artery stenosis is also association, especially the ostial type, hypoplasia and arrangement of the all three vessel wall elements including intimal proliferation, media thinning, and excessive adventitial elastin production. This is a microscopic picture for the ostial lesion. This is renal ostial stenosis with the fibroproliferation of the intima. We have thinning of the median and the excessive adventitial elastin production. This picture of celiac trunk stenosis, superior mesenteric artery stenosis at the lateral view aortograph. Clinical picture for the mid-aortic syndrome. Number 1, uncontrolled hypertension and headache. Number 2, occasionally exercise-related lower extremity fatigue. Association with the spanking artery occlusion will cause symptomatic intestinal ischemia, but is rare presentation. Association with renal artery stenosis will cause hypertension, headache, flash pulmonary edema, and renal insufficiency. Untreated case complication with left ventricular hypertrophy, congestive heart failure, and stroke. So we can discuss and summarize this clinical picture by the following video.
Mid-aortic syndrome is a very rare but serious condition that occurs in children and young adults. It affects the middle part of the aorta. The aorta is your body's largest artery. It runs from the left ventricle of the heart down through the abdomen. Your heart pumps blood into the aorta, which then supplies oxygen-rich blood to blood vessels that serve the rest of your body. In mid-aortic syndrome, the middle part of the aorta is narrow. This means that the same amount of blood now needs to move through a smaller space. This can result in reduced blood flow to the organs in the abdomen, including the kidneys and intestines, as well as the lower limbs. It can also lead to a related condition called renal vascular hypertension, which is high blood pressure caused by decreased blood flow to the kidneys. Sometimes very high blood pressure is the only symptom of mid-aortic syndrome. However, this condition can cause other symptoms, including headaches, seizures, and discomfort or weakness in the legs after exercise. Mid-aortic syndrome and renal vascular hypertension can lead to stroke, heart failure, and kidney failure, and can be potentially life-threatening.
This is a video from the Boston Children's Hospital. So the clinical picture are uncontrolled hypertension, headache, lower extremity fatigue, symptomatic intestinal ischemia in association with spanking artery occlusion, hypertension, headache, flash pulmonary edema, and renal insufficiency in association with renal artery stenosis, and untreated case will die by the form of left ventricular hypertrophy, congestive heart failure, and stroke. Differential diagnosis with Takotsubo arthritis and neurofibromatosis. But in Takotsubo arthritis, the patient is generally older, show clinical signs of arthritis including increased ESR, as well as malaise, fever, night sweat, anorexia, and weight loss. In addition, the frequent involvement of the pulmonary arteries may lead to dyspnea, which is not seen in patients with mid-aortic syndrome. So the Takotsubo arthritis is older and has increased ESR and systemic manifestation, and it would affect pulmonary artery causing dyspnea. So what the investigation? We have renal duplex CT angiography, MRA, and angiography, and we have advanced androgen, which is common with any type of investigation for any disease. Renal Doppler sonography has a risk of operator dependent. Small vessel structure may be difficult to be visualized, but has an advantage of no ionized degradation, low cost, and widespread availability. CT angiography has disadvantage of ionized degradation and iodinated contrast, but it has a benefit of rapid imaging, excellent spatial resolution, excellent contrast resolution and permit for reconstruction in 2D and 3D. MRA has this advantage of high cost, limited availability, lower spatial resolution, and may exaggerate an area of the arterial narrowing. Artifact may result from implanted metal or patient motion. Young patient may require for anesthesia. It has advantage of excellent contrast resolution for 2D and 3D reformation, no ionizing gradation, and may obtain image with and without intravenous contrast material. Conventional catheter-based digital subtraction angiogram. It has this advantage of invasive. The young and children may require anesthesia, and it carries risk of ionizing radiation. The advantages are best spatial and temporal resolution, produce excellent image of the renal arterial lumen and branches, advantage of concurrent therapeutic intervention in the form of endovascular management. This is the picture of CC angiography with contrast. It is the video for transverse cast at the following. This is the aorta, descending aorta. We have here stenosis starts with hypoplasia and narrowing from this point. I can repeat it again. Okay. So another time. This is the stenosis and narrowing or hypoplasia of the aorta. The management of the developmental aortic, renal, and splanchnic artery disease remain complex process that is best managed with the collaboration of the multiple specialty, nephrology, vascular surgery, physiology, and cardiology. All may be routinely contribute valuable insight into the diagnosis, follow-up, and management of these patients. Medical treatment. Pharmacological treatment of the hypertension in a very young children may be difficult and require frequent and careful monitoring. Failure of the medical therapy should be a reason to consider surgical or endovascular treatment. ACE inhibitor, ARBs, and beta blocker, alpha beta blocker, labetalol, diuretics, all are options. It is recommended that a single agent be initiated until the target blood pressure is reached or until the maximum dose or a side effect of the drug is encountered, at which time an additional agent should be added. Aortic reconstruction. We will start to discuss the open option for the aortic reconstruction. The first one is patch angioplasty. It's preferred in isolated abdominal aortic stenosis of short segments. Large enough diameter of the aorta allow completion of the anastomosis without an overlap of the suture from the opposite side of the patch. Aortic patch in the children are sized large enough to facilitate and match the growth of the remaining aorta and should be interrupted suture. BTFE expanded polytetrafluoroethylene graft are favored over the woven or knitted graft for both patch aortoplasty and thoracoabdominal bypass grafts due to the greater stability of the BTFE regarding post-implantation dilatation. So the patch angioplasty is preferred for isolated short segment abdominal aortic stenosis and narrowing. It needs also a considerable diameter of the aorta or large size enough diameter of the aorta so you can complete your anastomosis of the patch without overlapping suture from one side to another side. In case of the children, be careful. You have to make an interrupted suture and to choose a large sizable patch and is large enough to facilitate a match with the incoming growth of the remaining aorta. The type of the patch is expanded BCFE, which is preferred being it has less risk of dilatation. This is the case of patch aortoplasty. The MRA, we have suprarenal coarctation, this one, with the lateral renal artery ostial stenosis. Patch aortoplasty will underwent this patient and receive this patient with aortic diameter exceeding that if uninvolved proximal and distal aorta. This is a case of celiac trunk stenosis. We have superior mesenteric artery stenosis. We have intrarenal mid-aortic coarctation and narrowing. We have right ostial stenosis. We have left ostial stenosis. We have here also right what's called the left right and left renal artery stenosis, but we have here prominent stenosis. Okay, the patient underwent aortoplasty, aortic patch, and we have here incision at the ostium of the superior mesenteric artery and make a dilatation and implantation of the celiac trunk over the ostium of the superior mesenteric artery. We have re-implantation of the bottom renal artery inside the aorta. Again, number 1 for the celiac trunk stenosis, number 2 for the superior mesenteric artery stenosis. We have intrarenal mid-abdominal aortic coarctation. We have right and left renal artery stenosis. We have number 6 superior celiac trunk implanted into the stenotic superior mesenteric artery origin. Number 7 widely patent superior mesenteric artery. Number 8 is the BCFE patch. 9 and 10 for the implantation of both renal artery. Thoracoabdominal bypass preferred for long narrowing or very tight narrowing, which decrease the chance of the bulge anastomosis. Thoracoabdominal bypass procedure are frequently undertaken with concurrent complex renal and splanchnic artery reconstruction. The inflow of the bypass arises from the distal thoracic aorta above the diaphragm using thoracoabdominal approach, or from the supraceliac aorta and the diaphragmatic hiatus by midline abdominal approach, and in children, transverse supraumbilical abdominal incision extend to the posterior axillary line plus medial visceral rotation. So thoracoabdominal bypass is preferred for long narrowing and very tight narrowing. We doesn't have a considerable aortic diameter, which is a possible or an option to make an aortoplasty, patch aortoplasty. And also it's common in case of complex renal and splanchnic artery reconstruction and association. And the inflow from the thoracic aorta, we have to do thoracoabdominal approach. If from the supraceliac aorta, midline abdominal approach, or supraumbilical transverse abdominal approach for the children. And we have to choose BCFE is preferred conduit. The grafts are positioned behind the left kidney, so the tunneling will be behind the left kidney with a gentle curvature to the distal aorta. Diameter choosing 8 to 12 in case of young children, 12 to 60 mm for the adolescent, 40 to 20 mm graft in late adolescent and adult. It is not essential to leave significant graft redundance if you are treating children more than 10 years, because axial growth from the diaphragm to the pelvis is not significant. So, what the type of your conduit? BCFE. Where is the tunneling? Behind the left kidney. What is the size? As we have said, this is 8 to 12 in case of the children, 12 to 16 for the young adolescent, 14 to 20 for the adult. It is not essential to leave significant graft redundance if you are treating children more than 10 years. This is a picture of the suprarenal coarctation with the superior mesenteric artery stenosis. We have in the second picture thoracoabdominal bypass with aortic implantation of the superior mesenteric artery. So this is the suprarenal coarctation, stenosis of the superior mesenteric artery, bypass, and the reconstruction for the superior mesenteric artery and implantation into aorta. In this picture we have number 1 celiac trunk stenosis, number 2 superior mesenteric artery stenosis, Number 3, suprarenal mid-abdominal aortic coarctation. Number 4, right renal artery ostial stenosis. Number 5, left segmental renal artery stenosis. So number 6, this is a celiac trunk implanted into the aorto-superior mesenteric artery bypass with the autologous internal iliac artery graft. Number 7 is the superior mesenteric artery reconstructed one. Number 8, thoraco-abdominal aortic bypass. Number 9, right renal artery reimplantation into the aorta. Number 10, left segmental renal artery implantation into the adjacent segment renal artery. So again, celiac trunk here become implanted into the conduit of internal iliac artery between the aorta and the superior mesenteric artery. Superior mesenteric artery stenosis treated by the bypass between the aorta and the superior mesenteric artery using internal iliac artery conduit. Stenosis in the renal artery has been treated. The right one is re-implanted into the aorta, and left segmental renal artery implanted into the left renal artery proper. And we have here, this is the thoraco-abdominal aortic bypass, and the type is BCFE, and the tunneling behind the left kidney. In this picture, we have absence of the abdominal aorta and agenesis of the proximal renal arteries and extensive collateral vessels, and this patient underwent a complex thoraco-aortobiliac bypass with the bilateral renal artery reconstruction and reimplantation in this picture. So it was agenesis or absence of the abdominal aorta and renal artery extensive collaterals, and the complex thoraco-aortobiliac bypass with the bilateral renal artery reconstruction. Renal artery repair. What's the open option or surgical option for the renal artery repair? Brief facts. Consideration may include whether or not both renal arteries are involved, the length of the stenotic disease, whether segmental renal branches are also narrowed. Renal revascularization are more likely to be successful and more durable after the age of 3 years. But in case of infant, we have a technical challenge exists in reconstruction the very small and highly vasoactive arteries. So, what are the methods of reconstruction? Number 1, renal artery implantation is the most common option for the surgical reconstruction of the renal artery. So, the brief facts are consideration: you have one kidney affection, both kidney renal artery affection, was the length of the stenotic disease, you have segmental renal branches or narrowed or not. The treatment will be a bit successful in the age more than 3 years, but will be technically challenging in the infant. Renal artery implantation is the most common type of reconstruction. This is a picture of aortograph using this catheter, and we have bilateral renal artery reimplantation, and after incision have been excised from the origin. This is the origin, the previous origin of the renal artery, and this is the reimplantation. Number 2, aortorenal bypass. Aortorenal bypass with an internal iliac artery graft. This is the aorta. This is the origin of renal artery. This is the graft, internal iliac artery, which make bypass between the renal artery and the aorta. Aortorenal bypass with the vein graft, as described in the past, is no longer recommended due to aneurysmal degeneration seen in more than half of these grafts at the follow-up. Less common type of reconstruction: resection of a stenotic segment of the artery with primary reanastomosis, focal arterioplasty, open operative dilatation, nephrectomy. What's the indication of nephrectomy? Multiple intrarenal stenosis not amenable to open in situ or endovascular treatment. Diminutive non-functioning kidney 2 to 3 cm in size. Nephrectomy is appropriate when the contralateral kidney is assumed to be sufficient to prevent renal failure. Number 7, renal autotransplantation. Renal autotransplantation has been suggested in case reports. It is safe, effective for complex segmental renal artery disease without associated mortality, morbidity, and has a reasonable long-term follow-up. What the renal auto-transplantation mean? That means you get the kidney outside and make the reconstruction is preferred in case of the complex segmental renal artery, and then again reanastomosis to the renal artery like a transplantation. Splanchnic artery repair indications. We have a solid indication when you have celiac trunca and superior mesenteric artery symptomatic obstruction. But we have also a relative indication. Relative indication to prophylactically reconstruct these vessels exists when performance of aortoplasty or renal revascularization. So you are making an operation and you have to reconstruct the aorta and renal. So a relative indication to repair also the splanchnic artery. But the solid indication when you have symptomatic obstruction. Internal iliac artery grafts are used to treat lengthy celiac trunca or superior mesenteric artery stenosis. In young patient, anastomoses are fashioned with intraoperative suture when reconstructing small arteries 2 to 3 mm in diameter. In older adolescent, continuous suture may be used to complete the anastomosis. Developmental celiac trunk or superior mesenteric artery stenosis in adult may be reconstructed with either vein graft or synthetic. Percutaneous transluminal balloon angioplasty with or without stenting in children for this splanchnic osteolesion is not appropriate and ill-advised. So the type of the graft to reconstruct splanchnic vessels internal iliac artery graft. You have to make intraoperative suture for young children. You have to make continuous suture for the older one. You can choose the type of reconstruction, vein graft or synthetic, in treatment of the stenosis in adult, and the percutaneous transluminal balloon angioplasty or endovascular management has a low rule or minimal rule in case of children, being we have a fibrotic osteal lesion and it has a poor outcome. Endovascular management for mid-aortic syndrome or developmental aortic disease. Can you treat the aortic lesion or aortic narrowing using endovascular treatment? Endoluminal intervention may have utility in treatment of selected focal abdominal aortic coarctation away from the renal and splanchnic branches, mostly commonly due to an aortitis. Developmental aortic narrowing are prone to significant recoil from the hypoplastic and fibrotic segment, and stenting may be required to overcome this. We have increased perioperative morbidity with complication rate that approach 30%, complication of aortorenal tear and rupture, complication of stent embolization, local complication at the site of the angioplasty pseudoaneurysmal formation. So the role of the endovascular management to treat the hypoplastic aortic disease when you have limited focal lesion away from the splanchnic and renal. You have a risk of significant recoil due to fibrosis and hypoplasia, and stent has a role. We have a complication of the endovascular management like aortorenal injury, tear, rupture, stent embolization, and pseudoaneurysmal formation at the site of the angioplasty, like in the common femoral artery. This is a case report from South Korea. We have here a two focal stenotic lesion of the aorta, aortic coarctation, and it has treated with stent graft. And the cause of the use of stent graft, they want a safety of risk of rupture. But in the literature, both types of the stent was used, either perimeter stent or stent graft. But in this picture, they have used covered stent graft in the South Korean, and they have wrote that it has a bit safety and we don't have risk of aortic rupture. We have increased incidence of restenosis and reintervention with the freedom of reintervention of only 55% at 1 year, 33% at 5 years. Long-term benefit of endovascular intervention remain unproven in children. Do you have endovascular management for renovascular disease? Intervention have provided major benefit in treating renovascular disease, particularly in young adults with fibromuscular dysplasia. The role of endovascular intervention in treatment of pediatric renal artery stenosis remains controversial. Excessive degree of radial force is required to dilate fibrotic lesion and accompanying injury to the diminutive artery. We have risk of thrombosis as a complication. Do you prefer use stent? No. Stents are not advised in renovascular disease as there is an increased risk of neointimal hyperplasia and recurrent stenosis. Finally, endovascular therapy should only be performed at high volume centers by an experienced team. So the role of the endovascular management in renovascular reconstructions is limited for the young adult with fibromuscular dysplasia, with a controversial role in the pediatric. We have strong fibrotic lesion and strong recurring, but the stent is not advised, and you have to avoid stent, being we have a high incidence of neointimal hyperplasia and recurrent stenosis. This is a renal arteriogram demonstrating incomplete stent expansion across the ostial. Developmental renal artery stenosis with notable in-stent stenosis in child with a multi-drug resistant renovascular hypertension. This is the case of a 15-year-old girl with rapidly progressive hypertension and the recent onset of anuria. Aortogram demonstrates bilateral renal artery occlusion. Then patient underwent post-dilatation aortogram. She underwent endovascular management, balloon angioplasty and dilatation for both renal artery, and we show recanalization of the renal artery bilateral. And the urine output began almost immediately after the angioplasty, and hypertension improved uncontrolled. Later on, after 6 weeks, the aortogram shows restenosis of the right renal artery, and the left renal artery remained widely patent. And the patient received again angioplasty and balloon dilatation for the right renal artery, and now both renal arteries are patent. As before, hypertension resolved with minimal medication immediately after angioplasty. But later on, 5 months later, both renal arteries are again narrowed. And the disease has progressed to narrow both supra-infrasegmental aortic region, supra and infrasegmental renal aortic region, as well as the origin of the superior mesenteric artery. So finally, the patient shifted to the open bypass. This is the thoraco-abdominal bypass. Post-operative aortogram demonstrating aortic bypass graft and the bilateral aortorenal graft. Now we have finished the presentation, but there are two recent optional treatments under research and under observation, and is carried out only by Boston Children's Hospital. We have MAGIC and we have Tesla technique.
As you learned in the last video, mid-aortic syndrome is a very rare but serious condition that occurs in children and young adults. If left untreated, it can be life-threatening. The first step in treatment is to try to get the child's blood pressure under control with medication. Depending on the child's unique situation, we may use minimally invasive approaches to treat mid-aortic syndrome. However, more severe cases usually require surgery. When cases of mid-aortic syndrome with longer sections of aortic narrowing are treated surgically, physicians have traditionally used a prosthetic graft made from synthetic material to perform an aortic bypass. While used successfully in adults, synthetic grafts can pose a number of challenges in children. Synthetic grafts don't grow with the patient, which means that multiple surgeries may be necessary through the years to ensure appropriate graft size. Artificial grafts also carry a higher risk of thrombosis and infection. In some children with mid-aortic syndrome, a blood vessel called the meandering mesenteric artery, or MMA, becomes enlarged in response to narrowing in the aorta and other blood vessels. To take advantage of this natural growth, surgeons at Boston Children's Hospital have developed an innovative procedure called Mesenteric Artery Growth Improves Circulation, or MAGIC. In the MAGIC procedure, surgeons use the MMA instead of a synthetic graft to bypass the narrowed aorta. In order to promote continued growth of the artery following surgery, surgeons make slits at each end of the MMA to increase the size of the connection to the aorta. This can help prevent the need for future graft replacement procedures because the child's MMA will naturally grow as they get older. Although this is still a new procedure, outcomes from the first few patients to undergo MAGIC are very promising. This approach was pioneered by surgeons at Boston Children's and is not currently offered anywhere else in the world. As you learned in the last video, mid-aortic syndrome is a very rare but serious condition that occurs in children and young adults. If left untreated, it can be life-threatening. The first step in treatment is to try to get your child's blood pressure under control with medication. Depending on the child's unique situation, we may use minimally invasive approaches to treat mid-aortic syndrome. However, more severe cases usually require surgery. The most effective approach for many children with mid-aortic syndrome is to replace the damaged portion of the aorta with healthy nearby blood vessels. However, this has been difficult in the past because the healthy vessels tend to be too short to adequately fill in for the vessels they are replacing. Surgeons at Boston Children's Hospital have created a method to lengthen the healthy portion of the aorta to make it long enough to replace the narrowed part. This is called tissue expander stimulated lengthening of arteries, or TESLA, and works best for cases where a short segment of the aorta is narrow. During the first stage of the TESLA procedure, surgeons place a tissue expanding device behind the child's aorta. Next, through a port located under the skin, fluid is added to expand the device about once a week. This process slowly lengthens the aorta over several weeks to months. During the lengthening period, doctors use a variety of blood tests and imaging tests to monitor the function and health of the aorta and surrounding organs. Once the aorta appears to be long enough, surgeons perform a final procedure to remove the tissue expanding device and replace the narrowed section with the newly lengthened aorta. Although TESLA is still a very new approach, it can help some children with mid-aortic syndrome, renal vascular hypertension, or both avoid multiple surgeries as they grow up. Our initial results are very encouraging, and we hope to use this major advance to make a difference for many other patients in the future.
The reference. Thank you very much for your attendance.